صباح الخير. أنا اسمي دكتور رامي محمود غريب، lecturer of physical therapy في ال Pediatric department, faculty of physical therapy. المحاضرة بتاعت النهاردة اسمها pulmonary rehabilitation in pediatrics. By the end of this lecture, the student must know the causes of respiratory failure, the common respiratory disorders, how to conduct a pulmonary physical therapy examination, and methods of chest physical therapy. Respiratory disorders is the major cause of both mortality and morbidity for children throughout the world. Respiratory illness is the most common reason for hospitalization in children with severe neurological impairment and is the most common cause of death in these children. It can be defined as a condition in which impairment of gas and exchange within the lung poses an immediate threat to life. It is important to mention the causes of respiratory failure. من ضمنهم small airway size, high incidence of respiratory tract infections, poor development of the ability to cough, طبعا immature immune system, pure mechanical advantage for the respiratory muscles, وعندنا برضو horizontal and round alignment of the chest, and greater work of breathing in preterm infants. This diagram illustrates the common respiratory disorders in pediatrics, which include asthma, atelectasis, IRDS, cystic fibrosis, or respiratory muscle weakness. Atelectasis, which is the incomplete expansion of lungs, has two types. في primary وفي secondary. The primary, in which the neonate is in the neonate as a result of pulmonary immaturity. The secondary بيبقى due to musculoskeletal or neuromuscular disorders. من the signs and symptoms في small areas ممكن الموضوع يبقى asymptomatic. في large areas cyanosis can be observed, a decrease for breathing sounds, dull percussion, with inspiratory retractions. Overall ممكن نقول ان prognosis بتاع atelectasis is usually good if the duration of the atelectasis has not been prolonged. Usually the disease process is not life-threatening. تاني حاجة هنتكلم عليها اللي هي respiratory muscle weakness. It may result from any disorders affecting any link in the chain of the neuromuscular events that produce contraction of the muscles. Children usually require physical therapy for deficits or impairments associated طبعا مع respiratory failure or delay in the motor skill development. The causes of respiratory muscle weakness: one, لو في central nervous system pathology, for example viral or encephalitis. Number two, لو في high cervical lesions resulting in total ventilatory paralysis, lesion في phrenic nerve. Number three, high thoracic or low cervical cord resulting in impairment of the thoracic musculature, which decreases coughing. نكمل causes بتاع respiratory muscle weakness. عندنا برضو acute inflammatory polyneuritis زي جليان باري، ممكن spinal muscle atrophies زي الدوشان، وممكن برضو نتكلم عن abnormalities of the thorax such as idiopathic scoliosis or scoliosis due to secondary neuromuscular disease, which results in the loss of mechanical advantage of the muscles. Asthma طبعا is a lung disorder with the following: عندنا airway obstruction or airway inflammation with increased airway responsiveness to a variety of stimuli. This is an illustration of the things that trigger asthma. عندي حاجات زي molds, feathers, طبعا certain foods, certain animals, pollen, will smoke. رقم 4 في respiratory disorders cystic fibrosis. It is the most common life-limiting genetic disorder. It is an inherited disorder taking an autosomal recessive pattern. Cystic fibrosis is a generalized disorder of the exocrine glands. Pancreatic enzyme deficiency, elevated sweat, electrolyte concentrations, or chronic suppurative pulmonary disease. بالنسبة للإنفant respiratory distress syndrome أو IDRS, it's a restrictive pulmonary disease that results from inadequate levels of pulmonary surfactant and lung immaturity. من غير inadequate amounts of surfactant, there is a decrease in lung compliance, an increase in the work of breathing, بيخلي الموضوع أصعب, و collapse of the airways and respiratory units, وبيبقى فيه mismatching between the ventilation and the perfusion. من the common signs of RDS عندي tachypnea, عندي nasal flaring, وعندي intercostal and substernal retractions and cyanosis within 4 hours of birth. The chest radiograph demonstrates a typical ground glass pattern which indicates interstitial involvement. قبل ما نبدأ نتكلم على الأسسمنت, there are certain points which have to be taken into account concerning the effective physiotherapy for the non-ventilated child with a respiratory illness. لازم يبقى عندنا knowledge of the pathological processes of common conditions, anatomical and physiological factors affecting respiration, the ability to use age-appropriate assessment techniques, the normal values of the vital signs, طبعا pulmonary function tests, ولازم يبقى عندنا effective use of a variety of treatment techniques. أول نقطة في الأسسمنت هي الهيستوري, which includes demographic data, name, age, date of birth, date of the initial evaluation. تاني حاجة birth history, full term ولا premature, the type of labor, incubation. Family history, which consists of the birth order, presence of similar cases in family or in relatives, or other medical history. To continue, note the medical history and the onset, course, duration of the current illness. We have to include any previous treatment, signs and symptoms, أي precipitating factors, or other investigations. في living environment which is the space and resources, who was involved in treatment, الفنتليتر والsuction devices. في نقطة الfunctional status والdevelopmental history. لازم نبقى aware by any previous surgeries related to the current condition, the medications the child is taking if any. زي ما قلنا clinical tests including pulmonary function tests or arterial blood gas values or exercise tests. The chief complaint, which is the family's main concern leading to the request for physical therapy. تاني نقطة طبعا هي physical assessment, which consists of inspection, x-rays, pulmonary function test, blood gas analysis. بنبص على rate, depth and pattern of respiration, auscultation, cough and secretions. أول حاجة في الانسبكشن هي general appearance, which consists of the consciousness of the child. In general, the child's body, normal or obese. A general look at the posture, kyphosis, scoliosis included طبعا. لو في مثلا bilateral edema, which indicates right heart failure. لو في أي monitoring devices, mechanical ventilator, oxygen mask, أو intravenous or arterial lines. تاني حاجة بنبص عليها الhead والneck. The child face often shows signs of respiratory distress or oxygen deficit as cyanosis. وبنبص على accessory muscles of respiration اللي هي neck muscles. This is a diagram illustrating the muscles which are involved in breathing. زي ما احنا شايفين في muscles responsible for active expiration including the internal intercostal muscles والabdominals طبعا. عندي accessory muscles of inspiration, sternocleidomastoid والscalenii. والmuscles responsible for inspiration اللي هي external intercostal muscles وطبعا الdiaphragm. بالنسبة للنقطة بتاعت examination of the chest، أول حاجة unmoving chest، لازم نبص على الشيب والسيمتري بتاع الثوركس. رقم 2 لو في أي unusual characteristics of the skin زي scars أو incisions. لازم تعرفوا إن الثوركس of the infant is more rounded compared to the adult. The anteroposterior diameter of the thorax in the infant is likely to be equal to the transverse diameter. With the adult thorax, this is usually a much greater transverse diameter. بالنسبة للmoving chest، the respiratory rate, younger the patient, the greater the normal resting respiratory rate. The inspiration to expiration ratio, asthma or bronchiolitis, the ratio may become 1 to 4 or حتى 1 to 5. The rate and regularity of the breathing with chest wall retractions or indrawing may reduce effective inspiration. بالنسبة للchest abnormalities، thoracic deformities should be examined including pectus excavatum, carinatum وbarrel chest, scoliosis برضو. The examples of congenital anterior chest wall deformities will be demonstrated in the following slides. This slide demonstrates a funnel chest. This slide demonstrates a pigeon chest or pectus carinatum. With following diagram demonstrates the polar syndrome, which refers to the congenital absence of the pectoralis major and minor muscles ribs, and breast abnormality. The etiology is unknown. طبعا في الاسسمنت نقطة الاسكالتيشن دي بتبقى مهمة. We usually use a smaller version of the stethoscope than that which is used for adults. The therapist should warm the stethoscope before using it. طبعا depending on the age of the child, the therapist may show how I'll demonstrate on a child's doll. Because of the proximity to the thoracic surface of the child's airways, as well as the thin chest wall in the young child and infant, sounds are easily transmitted and anatomically specificity may be reduced. الموضوع عادة بيبقى أسهل. During auscultation, abnormal breathing sounds which we can hear أولهم الويزز بتبقى musical sounds produced by airflow through narrowed airways. ممكن يبقى inspiratory أو expiratory. الاكسبيراتوري بيبقى بسبب ويزز الاكسبيراتوري بيبقى غالبا بسبب البرونكوسبازم or secretion. برضو included في abnormal breathing sounds crackles which are non-musical sounds ممكن يبقوا inspiratory أو expiratory. Inspiratory crackles represent previously deflated airways opening suddenly. Expiratory donate fluid in the larger airways. لو في rubs برضو it's considered abnormal breathing sound, indicates or donates leathery inflammatory tissues rubbing against one another. This is an illustration of a normal chest x-ray demonstrating the color of the bone, the fluid with blood, with lungs. عشان برضو ناخد فكرة general عن الnormal respiratory rates. الانفنت between 30 to 60, toddler من 24 ل 40, preschooler 22 ل 34, الschool age child من 18 to 30, الadolescent 12 to 16, والadult from 10 to 20. هنبدأ نتكلم عن الchest physiotherapy بس الأول we have to exclude children who have acute bronchiolitis, whooping cough, narrowing of the respiratory tract زي البرونكوسبازم أو أي procedure في bronchoscopic removal of a foreign body. Physical therapy, chest physical therapy in pediatrics consists of three main areas. عندي airway clearance, وعندي breathing exercises, وعندي physical reconditioning. من the most common methods used for airway clearance طبعا هو postural drainage. It is the use of gravity assisted positions to drain secretions into larger airways. In the youngest children, the upper lobes are vulnerable to secretion retention, but with maturity and more time spent in upright positions, زي sitting or standing, الفوكس بيتنقل للlower lobes. This is a slide that demonstrates the positions we use for postural drainage in the upper lobes, superior segments, posterior والanterior. هنا بنشوف الposition assumed عشان نعمل postural drainage للlower lobes, posterior segments. Also included and most commonly used هي الactive cycle of breathing technique. Periods where there are periods of breathing control, relaxed abdominal breathing, deep breathing with inspiratory holds, thoracic expansion, mid to low lung volume huffs and coughs if required. It is often used in combination with postural drainage and percussion applied during phase of deep breathing. Positive expiratory pressure. PEP is thought to be effective in both reducing air trapping and enhancing secretion removal. The original technique relied upon breathing through an anesthesia face mask, but more recent devices use mouthpieces. It keeps airways open during exhalation by increasing intrabronchial pressure in central and peripheral airways, thus increasing functional residual capacity. This diagram demonstrates a positive expiratory pressure. عندنا برضو autogenic drainage, where we enhance airflow in different generations of bronchi, so mobilizing secretion. It consists of phases of breathing. Firstly, low lung volume breathing unsticks the secretions, mobilized and collected by utilizing tidal volume breathing with a slightly prolonged exhalation. High volume breathing and coughing, which evacuates the secretions. Huffing or forced expiratory techniques consists of 1 or 2 huffs, forced expirations from mid-lung volume to low lung volume, followed by a period of relaxed controlled diaphragmatic breathing. Taught to children as young as 3 years, it is very effective in airway clearance in pediatrics. Huffing requires less energy expenditure than coughing. بالنسبة للcoughing, it is particularly difficult for the child who has لسه just undergone thoracic surgery. It may occur spontaneously as secretion are mobilized. بالنسبة لنقطة increasing the lung volume, positioning of the child should be the first consideration in maximizing respiratory function. A toddler can participate in games that require deep breathing and control of breathing. Asking the child to breathe in time to music can present the skill of paced breathing. Blowing bubbles from a bubble wand will help emphasize increased control and prolonged expiration, which may be useful for the child with obstructive disease. There are also methods for decreasing the work of breathing. Positioning the child in prone lying with the head of the bed elevated stabilizes the anterior chest wall, limiting inward collapse of the rib cage. Parents must not leave the child in this position. Positioning inside lying removes abdominal loading on the diaphragm, so increases diaphragmatic movement and basal lung expansion. Sitting upright increases lung volume by improving diaphragmatic excursion.